Hello, everyone, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Hudspeth. I'm the radio program manager for MS Focus Radio, and I'm joined today by Dr. Ben Thrower speaking to us about MS and fatigue. After the presentation, we're going to open it up for your questions and comments. And a lot of you know Dr. Thrower, but if you don't, he is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, Georgia. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. And Dr. Thrower is a senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to our quarterly MS Focus magazine. When Dr. Thrower is not dressing up as the pirate Jack Sparrow, he can be found playing with his new grandson named Sam. And we're all pleased to have him join us to present this important topic about MS and fatigue. Dr. Thrower, thank you for being with us again, and I'll turn it over to you.
Great. Thank you, Chris, and thank you to everyone at MS Focus. We, on behalf of the MS community and MS healthcare providers, we really appreciate all that you folks do. Thank you to our sponsors who allow these programs to occur. So this afternoon, we're going to talk about fatigue and multiple sclerosis, and it could not be in a more important topic, and we'll go into why it's so important. I feel like sometimes when I say that, I'm preaching to the choir, because I suspect many of you on the line know how important fatigue is in multiple sclerosis. Many people with MS would say that this is one of their most bothersome symptoms. It is the most commonly reported symptom in the MS world. Again, many people with MS would list it as their most bothersome symptom. Depending upon whose survey you look at, it is either the most common or the second most common cause of vocational disability in MS. It vies for that dubious distinction with cognitive dysfunction. And again, depending upon which survey you look at, it's either the first or second most common cause. One of the things that is so interesting about fatigue and cognitive dysfunction leading to vocational disability is, to the average person on the street, they're largely invisible symptoms, and that leads to a lot of frustration, both at work and at home, with fatigue not being something that's readily visible. It's not like a big neon sign comes on your forehead, letting everyone around you know that you kind of you're running on empty. So there's been a lot of mixed research on whether fatigue is more common with certain types of MS, for instance, relapsing remitting versus progressive MS. And there have been some studies that have said that, surprisingly, it doesn't seem to correlate with progression of disability. So sometimes, again, our folks who look really good, apparently don't have many gait issues, for instance, can sometimes really be suffering from quite a bit of fatigue. So again, there's not a great correlation with type of MS or with level of disability in multiple sclerosis. So I like to think of fatigue as sort of a somewhat malevolent 8-armed octopus, if you will. And so we're going to talk about primary MS fatigue that is directly related to your MS. And then we're going to talk about a little bit about the other 6 arms of the octopus that are sort of secondary forms of fatigue. So the 2 forms of primary MS fatigue are the top 2 arms, lassitude and nerve fiber fatigue. We'll go into great detail about those, but there are other things that can lead to low energy levels in multiple sclerosis. Sleep disturbances, mood disorders, medications. Many of the things we prescribe can unfortunately be sedating for people. Deconditioning, compensation. We'll talk about what that means. We don't mean that we're paying you for something, unfortunately. We mean that you're paying for something, and that the price that you're paying is decreased energy. And then other medical conditions can certainly contribute to decreased energy in a person with multiple sclerosis. So there's a model has been used to talk about fatigue and how it correlates with 2 other symptoms in MS. And some people have used an analogy of a 3-legged stool. So each one of the circles here is one of the legs of the stool. So fatigue is seen in about 75 to 95% of people with multiple sclerosis. We move over to the gray circle and we have mood disorders, depression and anxiety, seen in generally most surveys would say about 50% of people with MS at some point during their life. And then cognitive deficits, seen in about 50%. If you worsen any one of those symptoms, you may make the other two circles bigger. And so you see this overlap, how these things all come together. They affect QOL, quality of life. And as we said earlier, they affect vocational status. We throw in that orange lightning bolt from the side, stress, and stress can actually magnify any one of those circles. So you get all of these things playing off of one another. It can make it challenging to try to sort out which one is the biggest issue for a given individual. But you could also look at this in a positive light. If we treat one of these symptoms, we may positively affect the other two circles as well. So let's talk about primary MS fatigue. So lassitude is a type of primary MS fatigue. So it's non-exertional, non-heat related fatigue. Someone has literally just unplugged your energy supply for no good reason. So people have described it as feeling like there's a lead blanket thrown over your body, as you're like you're trying to swim with a fur coat on. It's just this overwhelming sense of heaviness. You know that you want to do something. You have an activity that you love to participate in, but your body is just not going to go along for the ride. The other type of primary MS fatigue is nerve fiber fatigue. So this is fatigue that is more exertional or heat related. So an example of this would be, you start off with an activity, say walking, and the first block you're doing pretty well, and then the second block, now foot's starting to drag a little bit. Next block, now the other leg's dragging a little bit, and so there's just this exertional sort of worsening of a level of functioning. Uthoff's phenomenon. Some of you may have heard that term before. So Dr. Uthoff was a neuro-ophthalmologist in the 1800s who, in the pre-MRI, pre-spinal fluid days, one of the ways that he would diagnose MS is by putting people in a warm tub of water. And so because he was an ophthalmologist, what he was looking for was dimming of vision when people would get overheated. We now use Uthoff's phenomenon to describe really any MS symptom that gets worse with overheating. And that's seen in probably 70% of people with multiple sclerosis. So going a little bit more again into lassitude, this again is that non-exertional, non-heat related type of fatigue. Interestingly, it doesn't necessarily correlate with what we're seeing on MRI. We're going to circle back to that point and talk a little bit more about some newer findings on MRI that may explain that phenomenon. It may relate to the actual inflammation in the immune system. Cytokines are chemical messengers that cells in the immune system use to communicate with one another. And many of the cytokines that are relatively overrepresented in a person with MS are inflammatory in nature. And there is a thought that these inflammatory cytokines may be part of what drives some of the fatigue that we see. So while we certainly don't understand everything about what causes lassitude and multiple sclerosis, these are some of the current thoughts. We think that those inflammatory cytokines, again, those inflammatory chemical messengers. So we said that on MRI that the number of white spots you have may not correlate very well with how bad your fatigue is. There's some newer research that's suggesting that damage in other parts of the brain that we've traditionally not spent as much time thinking about in MS, things like the thalamus and the cerebellum, that thalamic and cerebellar atrophy may actually be better predictors of fatigue than just the number of white spots that you have. And then increased brain energy utilization. So even though the brain accounts for a small fraction of our total body weight, it actually accounts for one of the largest users of calories. Our brain requires a lot of energy to run. And if you have put white matter lesions or disruptions in the electrical pathways in different parts of the central nervous system, your brain is working that much harder to try to overcome those sort of areas of electrical disruption, if you will. So you're using more energy to try to accomplish the same tasks. And this may lead to some of the fatigue that we see in MS. So what do we do to treat lassitude? This is the toolbox that you're working from. Interestingly, the top two, exercise and energy conservation, we're going to come back to exercise a little bit more later and speak more on that. It was not that long ago that the people with MS were told to not exercise, and we know now that it can be a useful tool in managing fatigue. Finding the right type of exercise may be very key to this. Some studies have suggested that not all exercise is associated with improvements in fatigue. So working with an exercise physiologist or a physical therapist to find the right sort of form of exercise can be crucial. Energy conservation. So typically this is going to be something that either a physical therapist, an occupational therapist, occasionally speech language pathologists do this. So they're trying to help you work more effectively, maybe help you learn how to structure your day so that you're doing your high value activities when your energy levels are better, learning how to delegate a little bit. What we see in some people with MS is that they really only come in two speeds. They come in asleep and 110 miles an hour. And when they have a good day, they might try to cram 3 days worth of activity into that good day because they know it's a good day and tomorrow might not be a great day. And so what they end up doing is then exhausting themselves, and then they're out of commission for the next couple of days. So sometimes the energy conservation therapist is just going to help you sort of structure your activity so that you're a little bit more effective. We have three classes of prescription medications that we can look at to help manage fatigue. Amantadine, old school anti-influenza drug that is just a fluky side effect, was found to give energy to about 40% of people with MS that take it. About 60% of people are going to see no benefit whatsoever with the amantadine. Generally, taking it twice a day, every day for a month or so, you're going to know which group you're in, whether you're going to be in the responder or non-responder group. Modafinil and armodafinil, Provigil, Nuvigil are the brand names. These are drugs that were designed to treat narcolepsy. They are what the FDA categorizes as a wake promoting agent. They get you very focused in the here and now, can be used to help manage fatigue. I would note that of these three prescription classes, the amantadine, the Provigil, Nuvigil, and then the stimulant drugs, none of these are FDA approved for managing fatigue and MS. We have no FDA approved treatment option for managing fatigue and MS. Why is that important? If we prescribe an inexpensive drug like amantadine to manage your fatigue, well, it's off label, it's not approved. Your insurance company is probably not going to care. They're probably going to cover that. It's inexpensive. If we prescribe an expensive drug like Provigil and Nuvigil that are off label, your insurance company may suddenly care and they may not want to pay for those medications. So we are sometimes at their mercy as to whether they're going to pay for this off label medication. What we have a lot of individuals do if their insurance carrier won't pay for these drugs is we might go to the Good RX app on your phone and have you actually look at just paying for them out of pocket using the e-coupons that are on there. These drugs can be $600 to $800 full retail cost per month using those Good RX apps. We're having individuals get them for about $40 to $50 per month out of pocket. The true stimulant drugs, so your Ritalin, Adderall type medications, would be another therapeutic option. Interestingly, I think most healthcare providers who work with MS and people living with MS who've tried these medicines would say that usually one of these is going to help out some. There was an interesting study that came out where they took a group of individuals with MS and they had 4 treatment groups. They had a placebo group, and then they had these 3 classes of medications. Everyone in the study with MS got to try out every one of the classes of drugs. So they would keep a diary and record how they felt on those. They would have a 1 month washout period in between switching. So they'd try amantadine, for instance, go off of everything for a month, go to Provigil or Nuvigil, try that for a month, go off of that, wash out for a month, then maybe try a stimulant drug, go off of that, go onto a placebo drug. They didn't know which medication they were on at a given time. What was interesting in this study is at the end of the day, the conclusion of the researchers was that they did not see any benefit from any of these drugs in treating fatigue and MS. And so I'm not sure how to reconcile that with what we see in real life. I mean, it was a well-designed trial, but it doesn't fit with what I see in the real world. So we'll have to see how that shakes out over time. The only reason I mention that is that I could see insurance carriers potentially using that as one more form of ammunition to argue against paying for any of these medications for people with MS. Acetylcarnitine is an over-the-counter supplement. It's part of the human energy production cycle, what we call the Krebs cycle. And there was a study that showed that 1,000 milligrams a day over the counter of acetylcarnitine did boost energy levels in about half the people that took that medication. It's a nice, safe, easy option to try out. What about diet and fatigue and MS? So about 2 years ago now, there was a study looking at about 261 people with MS, and they went on what you would call kind of a Mediterranean type diet, lots of fruits and vegetables, lower saturated fats. And what they found is that over the course of the study, people reported better energy levels. They also looked at blood markers for inflammation, and they had lower markers of inflammation. So maybe that gets back to those cytokines, those chemical messengers. Maybe we can, with diet, modify some of our levels of inflammation. Maybe that reflects back into better energy levels for people with MS. Shifting to that other type of primary MS fatigue. So this is nerve fiber fatigue. So on the top, what we have is the way nerve fibers should work in the central nervous system normally. So what we have are the areas of sort of green, that's your myelin. The yellow is the nerve fiber that's covered with the myelin. And so what you'll see are these little gaps in the myelin here. So what's going to happen is the electrical information is going to jump from gap to gap to gap. Very fast, very efficient way to get information up and down the central nervous system. Now MS comes along and it's going to throw a monkey wrench into that. It demyelinates that nerve fiber. So now that electrical information can no longer jump from gap to gap. It hits this big area of demyelination. It can't jump it. So you see the little dotted line here. Now that electrical information has to be reconducted in little baby steps, across there. That works, but it's not as efficient as the original equipment. And the problem with this is that it's prone to conduction block. So if you use this naked nerve fiber again and again and again, like with an activity, or if you raise your core body temperature, or you do both at the same time, you get conduction block. Electrically, it shuts down. You've drained the battery. There's going to be a period of time where that nerve fiber is not going to work. You're going to rest. You're going to cool off. That battery is going to recharge, and it's going to start working again. But that recharging period varies from person to person. Some people might be lucky and they can take a 20-minute break and have some cold water, and maybe they're recharged and ready to resume their activity. For other people, it might be an overnight recharging until they can start going again. So what do we do to treat nerve fiber fatigue? Well, if part of that conduction block is due to overheating, what if we look at cooling strategies? So that's one way to attack the problem. We have these two classes of medications, and it's really the same molecule. There's a very subtle difference between dalfampridine and 4-aminopyridine. What these drugs do, I'm going to shift back here, is they work on potassium channels on this naked nerve fiber. And so a lot of electrical conduction in these nerve fibers is regulated by potassium and sodium and calcium. So many years ago, researchers learned that if you modulate those potassium channels on this nerve fiber, you can change how effectively that nerve fiber conducts electrical information. So these two drugs classes are potassium channel modulators. 4-aminopyridine is a non-FDA approved compounded drug. It's been made in mom and pop pharmacies forever. We still put patients on this. And then this is your FDA approved version, dalfampridine. There's now a generic. So Ampero was the original name brand. There are generic versions out there as well. So we think of Ampera as the walking drug because that's specifically what it was studied for, and that's what the FDA gave it an indication for, was to improve the speed of walking. We never thought of 4-aminopyridine as just a walking drug. we thought of foraminopyridine as a medication that would help with any of your symptoms that are heat or exertion related. So let's say you are a tennis player, and as you get overheated, your eye, where you'd had prior optic neuritis, maybe your vision starts getting a little bit blurry, and now you've lost your depth perception, and now your tennis game is off. So we've had instances where we put that sort of person on foraminopyridine, oral drug twice a day by mouth, and they can go longer with that tennis match before their vision dims out. Or maybe for someone it is their walking that gets worse as they go a long distance, or if it's hot outside. So we can use either of these classes, the foraminopyridine or the dalfampridine. Your response rate, your chances of getting a good benefit from these drugs is about 40 to 50%. We don't understand why that is. In our mind, we would think that, well, everyone with MS has this demyelination, so everyone with MS should get some benefit from one of these molecules. In reality, again, it's about 40 to 50% of individuals who are going to see benefit, and you're going to know after being on the medication for about 4 weeks if you're in the responder or the non-responder group. We don't want to use these medications in someone with a history of seizures. There's a fine line between improving electrical conduction in your brain or spinal cord and actually doing a little too much of that and provoking seizures. I've seen situations in people with different MS-related pain, like trigeminal neuralgia or central neuropathic pain, burning in your extremities, where these medicines have worsened that pain. And again, it's not too much of a stretch to say, well, if those pain syndromes are related to abnormal electrical crosstalk in the brain and spinal cord, and now we give you a medication that improves electrical conduction, maybe it could also improve that abnormal crosstalk, and so maybe we can make your pain worse. It's not permanent. If we stop the medication, the pain is going to go back to your usual baseline. Cooling garments, we've come a long ways. So there are all kinds of cooling vests that are out there. There are vests and hats and neck wraps. They've come a long ways from just our old ice packs. Now we have some much thinner versions like the one you see in the picture there, a little bit more user friendly. And then our wonderful folks at MS Focus do have the cooling program. Someone from MS Focus can correct me if I'm wrong on the timing here, but I think we're usually taking applications for the cooling vest program from February till June, thereabouts. And I would encourage you, if you have any sort of heat-related symptoms, take advantage of a cooling vest. We want you to be able to get out and enjoy things and not feel like you're just locked into your air-conditioned house, apartment, or condo during the warmer months, which I guess in Florida is probably most of the year. We have people that sometimes improvise their own cooling vests. So camelbacks, if you're not familiar with this. So camelbacks were originally designed for the military. It's a little backpack that has a bladder within this backpack, a little screw off lid that you can put water and ice in there, and then this tube that comes up over your shoulder and clips onto the front strap so that you've got your great cold beverage there. And if you put enough ice in this thing, it's right over your core, so it can act as sort of a little cooling vest. These are very inexpensive. They come in lots of neat colors. I want to say on Amazon you can get these for about $40. So one other kind of cooling option for you. So shifting over to some of the other arms of the octopus again, or maybe the other legs of that three-legged stool. So mood disorders and MS. Depression is unfortunately common in people with MS. We used to think that depression was just situational. It's because of what MS is throwing at you in your life, but we know now it's part of the biology of MS. It can be situational. MS presents some life changes and challenges for people, which can be very stressful, but your life could be wonderful. Everything's going along great, and you might still have some issues with mood because of the biology of what MS is doing in the central nervous system. So one of the symptoms that can be associated with MS is anhedonia, a lack of hedonism or a lack of desire to do things that would be pleasurable or fun. So one of the challenges is, how do we separate out fatigue, a lack of energy to do something, versus anhedonia, a lack of desire to do something, and also realizing that you may have both of these things, and it may be different on one day than it is the next. One of the questions that I ask that helps us sort out which camp you might be living in at a given time is, Imagine you want to go out to dinner, and we're probably talking, pre-COVID. You're going out to a great dinner. You've really been looking forward to this, and the night comes to do this, and you're just not up for doing it. Do you still have the desire to do it, and it's just that your body's not going along for the ride, and now it's very frustrating to you because you really wanted to do this, you're just too tired to do it? Or is the actual desire not there? Do you just feel kind of about it? You're just not really into it anymore. So that latter is the lack of desire. That may be more depression related. If it's really the energy level, you still have the desire to do it, and so it's more your body not cooperating. And again, it can be a little tough to sort out, but it helps us maybe go down one path or the other treatment wise if we can try to determine which of those is the bigger issue for you. Treating underlying depression, we always want to think about counseling and stress management, getting out and moving, exercising, socialization. I think so. Our wellness program that we have here at Shepherd Center, one of the greatest benefits, I think, is not just the physical conditioning, it's the socialization, it's having people get together and seeing someone else. And then we get into medications we can also look at for helping manage depression. One of the things that I hear commonly when we think about the counseling and the medication pieces is we refer a lot of our patients out sometimes to psychiatry or to counseling psychologists. And I think it's important to know what those two different healthcare specialists do. The old-fashioned version of what we think psychiatrists do, that they're going to talk to you about how you feel about your mom and dad and your childhood, that's not what psychiatrists do anymore. Psychiatrists are largely medication managers. There are so many different treatment options out there from a pharmaceutical standpoint that's largely what psychiatrists do. If we're looking more to help dive into your past and your stressors and give you stress management tools, that's more what a counselor or psychologist is going to do. A lot of times they're going to work hand in hand. Some practices, the psychologist may be able to recommend a psychiatrist or vice versa. Psychologists also don't prescribe medications. That's one of the other big differences between those two specialties. Sleep disorders and multiple sclerosis. So when I'm working with a person with MS and we start talking about daytime energy levels, usually the first thing I ask is, how's your sleep at night? If the person with MS is not sleeping well, we're going to be struggling with fatigue, regardless of what we do for daytime energy levels. It makes me feel a little guilty sometimes putting someone on a drug like Provigil if their sleep is not adequate. To me, it almost feels like you're revving a car engine when there's no gas in the gas tank. It's just, unless that person has adequate restorative sleep, we may be asking a lot of their body by, trying to drive those daytime energy levels. Studies have shown that sleep disorders are surprisingly common in multiple sclerosis. Obstructive sleep apnea is probably one of the more common ones. If you said in the non-MS world, what does a person with obstructive sleep apnea look like? It's going to be more likely to be a guy. He's probably going to have a big neck. He may be a little bit overweight. In the MS world, that may not be true. We're just as likely to see a thin female dealing with obstructive sleep apnea as we are a big guy. So we need to keep that in the back burner. And if we have some suspicion of an underlying sleep disorder, we want to think about getting them referred over to a sleep clinic for a sleep study. One of the clues that a person may not be getting restorative sleep is how they feel first thing in the morning. So we know that primary MS fatigue can set up shop early. So you may have primary MS fatigue that starts at an hour after you get up. But if you feel good and well rested for even a short period of time, even 30, 40 minutes, and then your energy levels fall off the cliff, well, that person's probably getting good sleep. They may have more of a true primary MS fatigue issue. If you feel tired from the minute your eyes open, you don't feel like you've gotten restful sleep at all, you're just as tired when you get up as you were when you went to bed, you may not be getting good restorative sleep. Some of our common MS symptoms can interfere with sleep. So if your legs are twitching and jumping and spasming all night long, you're probably not going to have good normal restorative sleep. If you're having to get up to empty your bladder every 30 minutes, you're probably not going to have good restorative sleep. Those may represent targets for us to go after with treatment so that we can minimize those symptoms to get you better sleep, to get you better daytime energy levels. So, sadly, a lot of the medications that we use to treat various things in MS can be sedating. So some of our antidepressants, especially our old school drugs like amitriptyline, can be quite sedating. Sometimes we take advantage of that. We use amitriptyline to help with sleep, but we don't want it sticking around to the daytime and worsening your energy levels. Topiramate, Topamax, gabapentin can be sedating for some people. Some people will use over-the-counter sleep aids. Most anything that you use that has the word PM in it probably has Benadryl or diphenhydramine in it. That can be used to help get you to sleep at night, but in a lot of people, it's going to linger into the daytime and give you just a kind of a groggy, hungover sort of feeling. A lot of things that we use for spasticity, baclofen, tizanidine, clonazepam could all be sedating, or analgesics like hydrocodone, some of our bladder medications, and then in the disease modifying realm, our old beta interferons like beta-seron, Avonex, Rebif, Extavia, Plegridy, those things, and some people can have a kind of a flu-like sedating quality if we're not using those appropriately. So kind of circling back to that exercise concept, and I stole this from some of our physical therapists. The physical therapists, when they see someone, they sometimes use the analogy of a bucket of disability. So you've got your challenges that you're faced with. Maybe it's walking, endurance. And we think that the two ingredients in that bucket are hardwired damage in the central nervous system, so demyelination, damage to axons, to nerve fibers. And then the second ingredient is deconditioning. We don't know in a given individual how much of your bucket of disability is made up of these two ingredients. Is it 50-50? Is it 70-30? But in almost everyone, that deconditioning is an ingredient, and that ingredient is changeable. We hope we're going to get to a point someday in the near future where we can actually reverse damage in the central nervous system. And I do think we will get there. Until we can repair damage in the central nervous system, our best bet right now for making that bucket smaller is to attack the deconditioning. So if we can make the deconditioning ingredient less of a part of your bucket, we make the bucket smaller. And I think that's something we always want to keep in mind. We mentioned earlier how our thought on exercise has evolved over time from, and again, it's strange to think at one point we were at the bottom part of this slide where people with MS were told that exercise was bad for them. And then we evolved to saying, okay, it's not going to hurt you. It's all right for you, to now realizing it's actually very good for you. It's a very important part of the toolbox for managing multiple sclerosis. So one of the common questions we get is, what is the best form of exercise, for a person with MS? Should I be doing, an elliptical, a treadmill, pool, an aquatics program, yoga, Pilates? And the simple answer is the best form of exercise is the one you have access to and that you're going to stick with. If I give you an exercise to do and you have to drive 20 miles to get to a gym to do it, and it costs a lot of money to do it, and it makes you miserable, or I put you into an aquatics program and you really don't want to be in a bathing suit to do that, those are barriers. And we want to try to eliminate barriers to exercise where we can and really pick things that you're going to stick with over the long haul. So we mentioned compensation earlier. What do we mean when we say compensation? When we say compensation, we mean, so MS has thrown a challenge at you, and now you're having to work harder to accomplish your usual activity, but to get around that challenge. So maybe it's weakness, maybe it's poor balance. And I think one of the greatest examples of this would be foot drop. So if you have foot drop, most people with MS that have weakness in those muscles are going to raise your foot up off the ground also have weakness in their hip flexors. So as they get weaker, let's say you're taking a walk and now you're getting a little warm and you've walked a block or so, and now that foot's starting to drop a little bit. If it was only the foot that was weak, the ankle muscles, you would just pick your leg up. You raise your knee up higher so that you didn't drag that foot. You can't do that and typically with MS because if your foot is weak and dragging, chances are your hip flexors are going to be weak too. So what people do to compensate is they swing their leg out and around in a pattern called circumduction. Once you start circumducting your leg, you're using muscles to walk that you weren't designed to use. And it's a very exhausting, very tiring way to walk. It also puts a little stress on your knee and your hips and your lower back. So then people really fatigue quickly. There was an interesting study in 2019 that looked at how much energy people with progressive forms of MS used just to do their daily activities. And shockingly, they used 2.8 times more energy than a person without multiple sclerosis. So that may be contributing to that fatigue that we see. You're just burning a lot of calories to just do your normal daily stuff. So what do we do to decrease that sort of compensation? Well, we sometimes look at not only rehabilitation, the reconditioning part, but we also look at assistive devices. Can we give you a tool to use that's going to make it easier for you to accomplish that activity? Maybe it's an ankle foot orthotic, a brace, maybe it's a cane, a walker, maybe it's one of the devices, the electrical devices for foot drop, like the Bioness device, the L300 or the Walk8 device. Maybe we try to make your nerve fibers work more effectively with 4-aminopyridine or Empira. But any of these things can be potential tools. What we don't want to see is people pulling back on their activity levels and say, man, I know if I go to the mall and walk, I'm going to be exhausted for the rest of the day. And I know they said I could use this 4-prong cane or maybe my ankle foot orthotic, and it would make me walk better and use less energy, but I really hate using that thing out in public. I think one of the big challenges that we see psychologically is people don't want to use assistive devices sometimes. They feel like it's like they're giving in or it's going to promote their dependence on that. When in reality, sometimes using the appropriate tool for the activity is going to make you more active, not less active, because you're going to have that device is going to let you get out and do more stuff rather than being afraid of pooping out in the mall and getting stuck in the middle of your walk. And then lastly, just because you have MS doesn't mean you can't have other health conditions. And so most people, we're all human. We have other health conditions come up. So, if you've got diabetes, thyroid problems, heart conditions, B12 deficiency, these things could contribute to your fatigue as well. I think it's vitally important when you think about your health team that you have a good primary care provider, a family doctor, or an internal medicine doctor as part of that team to make sure you're getting all of the routine health maintenance that you're supposed to get. We've said this many times in these discussions that if your MS neurologist is your primary care provider, you don't have a great primary care provider. We do the things we do well, but being a primary care provider is not one of those. So really having someone, a good family doctor or internal medicine doc as part of your team is really important. And I think I'll finish up with I love this cartoon. So the doctor is looking at the guy and he says, well, it could be anything. So this is your way too general practitioner. So you don't want a way too general practitioner. I put this up here too as kind of a nod to, I know it's frustrating sometimes when you see your primary care doc. There's a tendency, if you have MS, for people to want to blame everything that you have on your MS. You go in with a broken arm, they say, well, it must be your MS. There's a balance. Sometimes you do have to be your own advocate and push back a little bit and say, listen, I've discussed symptom X with my MS team and they don't think it's my MS. Sometimes concluding that a given symptom is your MS is a process of elimination. Because MS can do so many different things to different people, there are a lot of symptoms that could fall into the MS bucket, but we want to make sure we're not missing other stuff. And so sometimes we rule out all the other stuff before we say, okay, the family doctors checked everything out. This is not thyroid disease, it's not diabetes, it's not heart disease. So maybe we circle back to it being your MS, but we don't want to make that our automatic default position. And then with that, I'm going to throw it open to you guys. These are two of my babies at home. This is our grandson, Sam. We're expecting grandchild number 2 around Christmas time. And then this is one of our two fur babies. This is Scout. She is now about 80 pounds bigger than that. She's a Shiloh Shepherd and just an absolute joy. If you're ever looking for a great Shepherd breed, I'd encourage you to check out the Shiloh Shepherds. They're bigger than German Shepherds. They're a little mellower and not quite as demanding and high need.
That's awesome. Thank you so much, Dr. Thrower, for all you do, and we are ready for questions. If anyone has a question or a comment, please make sure to raise your hand in the app or send your questions via chat. To raise your hand in the chat in Zoom, just click the screen to pull up the menu and select more. It's the icon with the 3 little dots, and click raise hand. Then I'm going to unmute you, and a button will appear on your screen asking if you want to allow me to do that. And please select allow, and then you'll be able to ask your question. So we do have a couple of questions and comments in the chat. One is from Karen, who says she takes Ampera twice a day, and she has blood in her urine, and then has she's curious why that might be happening.
Yeah, so you definitely want to get that checked out, Karen. So Ampera in the studies was associated with a slightly higher risk of urinary tract infections, which honestly we don't understand based upon how Ampera works, but it is what it is. I would be very leery of writing the blood off in your urine to the Ampera. So you need to get someone to take a look at that and give you a good explanation. I mean, if they come back and they want to try you off the Ampera for a while, that's fine, but I would not automatically assume that it's the Ampera that's causing the blood in the urine.
All right. And she has a couple of other questions while we wait for others to send in some questions. She says her legs get fatigued and can't lift her leg across her knee to tie a shoe, and she does exercise, but if you have any suggestions.
Yeah, so that's the hip flexor weakness that we're talking about. And that's one of the common ways that'll manifest is just getting that hip flex to cross your leg over to tie shoes. So, if you've not worked with a physical therapist, I'd really encourage you to do that, to try to get as strong as you can be. There's some interesting research out looking at something called FES bike, functional electrical stimulation bicycle. So this is a stationary bike, and then you have electrodes at different major muscles on your leg. And as you fatigue, that functional electrical stimulation machine is going to start firing your muscles for you. The question that we had with those clinical trials is, does using that sort of exercise translate into better endurance and better strength in the daytime? And it did. So you could ask a physical therapist about that sort of exercise program. There's other research that has looked at something called down slope treadmill. So when you think about a treadmill, normally we think about a treadmill being flat or elevating, like you're walking up a hill. One of our local Emory exercise physiologists did a study, and he said, well, I wonder what would happen if we put the treadmill this direction. So we're acting like the person's walking downhill. Does that translate into better leg strength over time? And it did. It was an interesting exercise in that people felt like it was easier to do, and it gave better benefits. There's not a lot of exercises where you get that kind of combination. Easier to do, more benefit. So some of the newer treadmills out there do have that downslope feature. So what our local researcher did was 6 degrees of downslopes. If you don't have a newer treadmill, or your health club doesn't have that sort of treadmill, honestly, our local researcher did not have that treadmill. He took wooden blocks and put them under the feet, and sort of a 4x4 wooden block, and just jack the treadmill up in the back. If you do that, just make sure you're not binding your treadmill belt at all. You'll know if you bind the belt, it won't go anywhere. It's going to be a very short walk. But normally you have little feet on the end of your treadmills, and you can just put the block under that end.
Interesting. Let's see, a question from Judy. Do most MS neurologists feel comfortable prescribing mood drugs, antidepressants, and follow-up?
Yeah, good question. So you're going to find a range of comfort levels out there. I think most MS neurologists are going to be comfortable prescribing one mood stabilizer, antidepressant. Some are comfortable with a combination of the two. Generally, if you've tried one or two mood stabilizers, let's say you're on Wellbutrin and we add some Celexa to it, and we've maximized the doses on both of those, and that's still not getting your mood where you want it to be, most MS neurologists are going to want some help at that point. Just like we have had an explosion of disease modifying therapies in MS, there's been an explosion of mood stabilizers. And so we stay up on those, but we're certainly not going to be as cutting edge as a psychiatrist would be. So that usually at two meds is where most MS neurologists are going to want to get a little bit of help.
Okay. From Melissa, how well do the electrical devices with walking help with foot drop?
Yeah, I think in the right person, the electrical devices can be wonderful. We personally prefer the Bioness device to the walk aid. And the reason being is walk aid's a great device, but the way the walk aid works is it's set to detect the tilt and acceleration of your knee when you're taking a step. And so the physical therapist working with you has to set those parameters. The problem is your internal biological parameters are variable. They're not set. Your degree of weakness in your ankle dorsiflexors that are going to bring your foot up change throughout the day. You know this. You know that you function better at some times of the day than others. And so if you have a device where the parameters are set, it's going to work well sometimes and maybe not so well at other times. It's not adaptable. Whereas the Bioness device actually reads your environment. So it's adapting to whatever your need is at that time. The only way that we really know if someone's going to do great with one of these devices is to get them in with a physical therapist and put them on and let them try it out. I may think in the exam room that someone's a perfect candidate and they go in and they're just not a perfect candidate. Some people don't like the feeling of the device. It just feels uncomfortable, that small electrical stimulus. So we refer people to our physical therapist for trials of the devices. If your local physical therapist is not comfortable working with one of those devices, they can call Bioness or WalkAid, and they will send one of their own physical therapists out to work free of charge side by side with your physical therapist to try one of these devices out to see if it's appropriate for you.
All right. We have another question in chat from Jim. He's asking about CBD and CBG to help with sleep.
I think so I'm a big fan of cannabinoids for different symptoms. So both CBD and CBG. So for people that don't know, CBD is the major cannabinoid chemical we find in hemp. It's legal in all 50 states. Any of the CBD products you buy legally out in any state of the union is going to have 0.3% THC or less in it. It can be a great sleep aid. It tends to be something that doesn't make you drowsy. It just helps you turn your brain off and tends to promote a much deeper and more restful sleep. CBG is kind of the parent cannabinoid. A little harder to find out there. So if you're just buying stuff over the counter, you're going to have a much easier time finding a high quality CBD product than a CBG product in general. And we've had good luck with the CBD. Pick a reputable source. You want something that's laboratory tested. Fortunately, there's so many good vendors out there. So if you Google CBD store near me, most people are going to pull up 3 or 4 places that are close by to them, and you can go in and ask them if this is a laboratory tested product, and just to take a bedtime. I think it can be great for sleep.
All right. Christian has a question. If you can speak about clemestine,
Yeah,
antihistamine, and for potential myelin repair.
Yeah, so clemestine was part of a project out of University of California, San Francisco, funded by the National MS Society, where they were looking for FDA-approved molecules that might, as just a quirky side effect, repair myelin. And so they developed a test tube model called a micropillar array to test these molecules to see if they could regenerate myelin. And then the beauty of using something that's already FDA approved is you already know it's safe. So if it worked in the test tube, you can go straight into a human trial. So the one human trial we have on clemestine, and I'm at a bit of a loss to know why we haven't seen anything else since this. But the original trial was 50 individuals with permanent visual loss from prior optic neuritis. All 50 were treated with clemestine. Clemestine is the active ingredient in Tavist. It's an antihistamine. And all 50 of these individuals had some degree of visual recovery over 6 months. The criticisms of the study is that it was small. It was only 50 people. And it was open label. There were no placebo groups. Everyone was unblinded. The researchers knew these people were on treatment. The people with MS knew they were on treatment. But I would argue you can't really fake visual recovery. And so it was a very objective improvement. So the questions are, how does that then translate into the bigger picture of MS? Could someone with walking issues have potential myelin repair with clemestine? If they do, how long does it take? These are things we just don't have the answers to yet. Clemestine is relatively well tolerated. The dose they used in the UCSF study was larger than what you would typically use for allergies. So there is the potential for sedation with it. I would say we've used it off label in a number of people. I've had a small handful of people believe that they had some functional improvement. So I think it's a reasonable benign thing to try out, and there is some science behind it. We'd like to see more trials on it.
All right. Again, if anyone has any questions or a comment, please make sure to use the raise your hand feature in the app, or send your questions via chat. If you do want to ask a question to the doctor directly, to Dr. Thor directly, make sure when I ask you to unmute, a little button will appear on your screen, and just select allow. We do have another question from David. So he's having a pool constructed this season and thinking of a stationary swimming for exercise and water exercises or any water exercises or tools you can recommend.
Yeah, I think that'd be an awesome thing to have available to you. I love aquatics programs for people with MS. It takes your weight issues away. If you get your pool temperature right, then you're taking your heat issues away. Ideally, what I would probably try to do is see if there's an aquatics program near you that maybe you could go and spend some time with to look at the different toys that they have and maybe try some things out to see what works best for you. There's a whole world of stuff out there. There are underwater treadmills, there are underwater bikes. I mean, you don't have to just having a pool. I mean, an aquatics therapist could design a program for you just with the different, paddles and whatnot, so you get some good resistance training. So if you could go somewhere and look and try something out, great. If not, I would probably go on to YouTube and just look at some of the videos of different toys that are out there. You should be able to get this written off on your income taxes as a healthcare expense. Your healthcare provider could probably just write you a prescription saying, all of your aquatics devices, those are legitimate medical needs. So if it helps you financially, I don't think, I'd be surprised if you could get your insurance company to cover them, but certainly you could get them written up on your taxes if that helps. We get questions sometimes on the pool temperatures that are out there, and the National MS Society has it written almost in stone that 85 degrees Fahrenheit is the pool temperature that we need to shoot for. 85 degrees Fahrenheit feels pretty cool to most people when you get in that water. I wouldn't get too hung up on that. If your pool in the summer gets warmer than that, let's say it gets up to 90 degrees, try it out and see. Everyone's different with MS. Some people with MS have no heat sensitivity and they're going to tolerate much warmer pool temperatures. You're going to know if you get in the pool and it's a little warm and then you get out, you just feel like a noodle, you're just exhausted. That pool temperature was maybe a little bit too warm for you. But just don't, I wouldn't say if you look at that 85 degrees, don't get too hung up on it and think that it's absolutely written in stone.
Okay. And kind of on the theme of everyone it's kind of different with MS, Teresa has a comment that she's tried electrical stimulation and it was painful. And maybe you could comment on what to do.
Yeah, so that's how we said when we send people to physical therapists for these different, whether it's a Bioness or walk aid or an FES bike, some people don't like that sensation. It is a small electrical stimulus, and if you've never had it, it feels like someone is kind of thumping you a little bit. And for some people, it's a mild little curious thump. For other people, it's a big thump. I would say if I had to generalize, thin women probably have the hardest time just because there's no padding and they really feel that stimulus and it's very annoying, bordering on painful to them. So no, I pardon the pun, I feel her pain. We've tried these devices on, and I know it can be a little bit annoying in the wrong person. So it's yeah, she's got a legitimate complaint.
And another comment from Teresa was that any form of weed slash I presume she's speaking of CBD or cannabis does nothing for her.
So if it's plain CBD, so again the hemp-based product, if you're trying to treat MS symptoms like spasticity, central neuropathic pain, urinary frequency and urgency, the CBD over-the-counter products that have 0.3% THC are probably not going to be as effective as you would like them to be. They can help with sleep, but they're not going to treat the underlying MS symptoms. What we've learned with those MS symptoms is you probably need the THC component that you're going to get from marijuana, not hemp. That's where things get really tricky is you get into ratios of CBD to THC, the milligrams in whatever you're using, the route of administration, oral versus vaporized. And so there's an art to this. And what we're trying to encourage people with MS to do is think of these cannabinoids as medication. Treat them like a medication. Know what you're buying, know what you're taking, know how many milligrams of different products you're getting. And ideally, you'd have someone who can advise you on that. Every state's different. Our laws in Georgia are different than the laws in Florida, or different than the laws in California and Colorado. So, hopefully we're going to get to a point where we have some standardization. We are starting phase 3 studies in the United States this month on Sativex. Sativex will be the FDA approved version of quote unquote medical marijuana. It is a 1-to-1 CBD THC sublingual spray for MS spasticity and spasms. We know it works. It's been available in 23 countries around the world for the past 10 years. There are multiple studies on it. We just need our studies in the United States to get our FDA to approve it. The beauty of that product is your insurance company would pay for it, and it's a pharmaceutical grade product. It's about as standardized and tested as you can get.
Okay, and she had a follow-up comment that it was mostly for pain, and it was CBD, to be clear, not cannabis. So
yeah, so plain CBD for pain management, most people are not going to be very happy with that. So if she's looking for pain management, she needs a CBD THC product, and depending upon the state that she lives in, she's got to look at the mechanics of how you go about doing that.
Sure. And one final a couple comments. Will there ever be a cure for MS? This is from Melissa.
Yeah, so I certainly think there will be, but I would step back from that and say cure means different things to different people. So if I'm a newly diagnosed 22-year-old who has minimal symptoms, cure for me means give me something that's going to guarantee that my MS is stopped dead in its tracks right now. I will never have relapses. I'll never have disability. I'll never have new lesions on MRI. That's different than the 50-year-old person who's been dealing with MS for a while and has some challenges, maybe has some walking issues. If I'm that 50-year-old person, I want something that reverses disability. I want a neural repair agent. So I think that there are different definitions of cure. I think for that 20-something-year-old person, we've got pretty good tools in the toolbox. And for a lot of people who are newly diagnosed, we are stopping their MS dead in its tracks right now with what we have. I think we're not quite there yet with that neural repair, but I do think we will get there.
Okay. And then just kind of a final, Susan would like to just, if you could name the spray that you were speaking of again, that's in testing, the 1-to-1.
Yeah, so the 1-to-1 CBD THC is called Sativex, Sativex. And so it is GW Pharmaceuticals out of the UK. They actually grow a breed of hemp that's very, very high in CBD. They grow a breed of marijuana that's very, very high in T. I always thought they had one hybrid plant, and they got both. They actually have two different plants, and then they blend that into that 1-to-1 ratio.
Okay. And final question of today is from Linda. She's been hearing about mRNA vaccinations for MS. Any hope with that?
Yeah, I think that's pretty cool. So, we've put up with a lot with COVID and the pandemic and whatnot. So Pfizer, in making their messenger RNA COVID vaccine, partnered with BioNTech in Germany. The BioNTech researchers are looking at the messenger RNA technology and realizing we can do a whole lot more stuff than just make COVID vaccines. As important as that is, there's a lot of other potential for messenger RNA. So messenger RNA is just a blueprint for a protein. So what they're doing with the idea of an MS vaccine is they're working on immune tolerance. What if we could teach your immune system to not attack myelin? So much like you would say, get an allergy shot. So what if we want your immune system to not react to ragweed anymore? So we're going to teach your immune system to tolerate ragweed. What if we could do the same thing with myelin? So they have the messenger RNA code for a small amount of myelin basic protein. Teach your immune system to not attack the myelin basic protein, but to tolerate it. So what we know so far is that in the mouse EAE, experimental allergic encephalomyelitis model, this worked. So the messenger RNA myelin basic protein vaccine for MS worked in the animal model. Now it's going into human testing. Realistically, we're probably looking at least 4 years. So we have the final verdict because it's got to go through phase 2 and phase 3. I don't think they've completed the phase 1 that I know of yet. So we know that the concept of immune tolerance works. The question is, can you harness the genie and get just that and not do anything bad? We certainly don't want to make your MS flare up in any way. So stay tuned. I think it could be really exciting. The messenger RNA technology right now feels like it has the potential to be what monoclonal antibodies are. A lot of our MS therapies, Tysabri, ocrelizumab, are monoclonal antibodies, and they're just endless possibilities with monoclonal antibodies. It feels like we may have another sort of big breakthrough with messenger RNA technology along those same lines.
All right. Well, thank you so much, Dr. Thrower. That's all the time we have for now, and we appreciate all the questions everyone had and comments. And if you missed any part of this conference, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page or our YouTube channel. And make sure so you can just search for Multiple Sclerosis Foundation on both of those channels. And make sure you join us next Tuesday evening at 7 p.m. Eastern Time for Healthier You, Healthier MS with Dr. Daniel Cantor. Make sure you follow us, MS Focus, on Facebook, Twitter, and Instagram for times and access information. And our sincere thanks again to everyone who attended today, and especially to you, Dr. Thrower. It's always great to see you. And we appreciate all that you do. Do you have any final thoughts? Any big summer plans?
Yeah, I just hope everyone stays healthy. I'm looking forward to things hopefully returning to normal at some point. My wife and I do, as some of you may know, we do medical work in Nicaragua, and we have not been able to go. Our last trip down was February of right before COVID broke, and so we're still taking care of the patients remotely, but we're hoping to get back down there soon.
All right. Well, thank you so much, and good luck with that. You do great work down there as you do at the Shepherd Center in Atlanta, and we hope to be able to see you in person again soon. All right.
Thank you. You guys all take care.
Yeah. Thanks, everyone. It's great to see everyone, and have a good rest of the day. Bye-bye.